Committee. I'm the vice chair of that subcommittee. And we're going to talk today about all of the changes to coding and billing and government policy relevant to Eurodyne practices during this public health emergency. I've introduced myself. We're also going to be joined this afternoon by Mamta Mamik, who is a member of our committee, by Jill Rathbun, who is the AUGS Health Policy Consultant. There are other members of the coding committee on the webinar who will be available for Q&A during the course of the webinar. Some housekeeping items. So we're live streaming now, and this will be recorded and will be available, I understand, on YouTube at some point in the near future. For attendees, you are all by default in the listen-only mode. Your microphones are muted and you can't activate them. That's to make it easier for the panelists to get their verbiage through and prevent any conflicts. But we do want and invite your questions and your involvement. We are going to have a polling feature. We have 3 poll questions that we want answered. And in fact, Colleen, if you can launch those polls now, you will see on your screen that the polls will pop up on a control called polls, which, at least for me, it's up at the top portion of the screen. Depending on what platform you're on, it may be in another location, but it should say polls, and those will be there. If you have questions, there is a similar button. It looks like 2 cartoon speech windows back to back called Q&A. And that's where we would ask that you place your questions. Those questions will come to the panelists, and we will be able to address them in the Q&A portion of the program later. If you have technical issues, problems with microphones, problems with video, we have AUGS staff monitoring the webinar, and if you'll put that in the chat function, there is should be a chat button as well on your screen. The chat button is not for questions. The chat button is for technical issues. At the end of this webinar, you'll be asked to participate in a brief survey. We're looking for feedback on the quality of the webinar, what you thought of it, other things that you might be interested in seeing. And again, the slides will be made available to all of the registered attendees. They'll also have the content posted on the AUGS webpage on the COVID-19 page. I've got to get this, there we go. So our agenda, we're going to talk about a variety of things. We're going to talk about the types of telemedicine services that are available now, the coding and billing rules that exist today, and in some ways how they contrast from what we were doing just a few weeks ago, the expansion of those telemedicine services due to the 1135 waiver. We're going to talk about telephone CPT codes, which are now available to be billed and have some value allocated to them. We're going to talk about CMS policy changes with regards to coding and billing and the waivers. Jill will talk about some of the financial resources that are available due to the various COVID-19 relief acts. And she's going to talk somewhat about the 4.0 stimulus plan that's in work. Our learning objectives, we're of course required to tell you our learning objectives. After this, you should be able to understand what telehealth CPT codes are and what they're supposed to be used to bill and how those services work. To construct documentation that appropriately supports the services that you're reporting with your billing. To understand the various authorities that CMS has waived during this emergency. We're going to hopefully clarify for you and allow you to identify the resources that are available to you financially with practice management, and to understand what's going to happen, or at least what we think might happen, with future changes and extensions in the future after all of this. So obviously there are challenges to our subspecialty during this public health emergency. We've got a very contagious virus that we're dealing with. The most susceptible patients are typically our patients, people over 60, people with medical comorbidities. These are the people who are most at risk, and those are the people that we typically see. It's prudent to limit their exposure to facilities and to other patients and even to providers. And in many places in the country, that's been mandated. Certainly here in Washington, Washington State, where I am, it's been mandated now for the better part of a month. We obviously still have to provide emergent care, but most of our stuff is non-emergent. And there are a variety of definitions about emergent and non-emergent and urgent and non-urgent, as far as what types of care can and should be rendered and what kind of things should be deferred until later. We all are under the pressure of being frontline providers, and we're forced to take on some roles, obviously, that many of us, well, haven't taken on for a very long time, or maybe haven't ever taken on. And then, of course, in the midst of all of that, you still have to pay the rent and keep the lights on by virtue of a revenue cycle or some form of RVU production, depending on how you pay. As of April 1st, there are some new codes. There's a new group of codes, a new chapter of ICD-10-CM for special purposes. It's the U00 to U85 chapter. And there's a specific new code, U07.1, which is specific to the COVID-19 virus that's available for reporting that diagnosis. So at this point, I'm going to pass the baton over to Mamta and let her talk to you about how to set up your telemedicine services. So Mamta, over to you.
Scott. Thank you so much. Good evening, everyone. I am going to start my screen, but I'm sorry, it's just taking a little bit of time here. Okay. Colleen, is it possible for you to share your screen, please? I'm having some technical difficulties here. Thank you. Okay, so I'm going to talk about setting up your telemedicine services today. And I'm going to start with talking about some of the platforms that are available. The first one I would like to speak about is the doxy.me, which is free and available to all the physicians. And if you could go back to the previous slide, please. And this is available to all providers, and it comes with a business associate agreement, which is something that you sign with the platform for protecting the PHI of the patients, and that is required also for just entering into an agreement about how the PHI is protected. So that is free. The next one is the Google Suite, which is also HIPAA compliant. It has a small charge to it, like between $12 and $15. Most people have been using Zoom as well, and that also has a fee to it for businesses. But all of these are HIPAA compliant. There are some services that are compliant with the electronic health records as well, and integrated with Epic. For example, the Amwell, the MD Live, Zipnosis, and the Teledoc. These also have apps, and they are very easy to use. I personally use the doxy.me. I've started using it since March, and I want to show you what you see once you sign in as the provider. Next slide, please. So this is the virtual waiting room. There's a patient queue here on the left, and you can send an invitation to your patients either by text or by email, and it's pretty much immediate that the patient gets it either on their phone or their email, and all they have to do is to click the link and put in their name, and they're in the patient queue here. And once they're in the queue, you can start a video conference call with them where they can hear you and they can speak to you at the same time. Occasionally, the quality of the video is not that good, so I do concurrent telephone call as well as a video call to try and make sure that the conversation is as smooth as possible. Next slide, please. So this one, for the basic services, it's free, and you can use it with a smartphone. You can use it with a computer, and you can, which has a webcam and a mic. And it has a virtual waiting room. And if you were to expand the clinic, meaning you wanted to add providers or administrators and nurses to process paperwork, that's still possible. And it costs $50 per provider, per medical provider. It does require a good internet service. It can be used from home of both the patients and the physicians if you pay for that service, and you can capture the photograph of the patient and the times and duration of the video conference as well. What is also beneficial for this is that you would do a screen share if you wanted to show patients the POCQ model and what their or the mechanism of incontinence, etc. You could do that. There's also the process of teleconsenting, which all of these require every single platform before you start the video or the audio televisit. One has to get a verbal consent from the patient and the photo capture. Next slide, please. So the workflow is obviously going to be very different. So the patients call in and they want to reschedule their appointments. At this time, we redirected them to telemedicine visits. And we divided them to see if they could be an in-person visit, which we tried to reduce as much as possible, or a telemedicine or a telehealth visit, or reschedule into the future. And usually we tell the patients that they'll be called within 90 minutes of their scheduled time. And also they're sent the link beforehand, so we're not scrambling at the last minute to do that. And usually the patients are waiting in the waiting area, so when it's time for their visit, you just start the video conferencing with them. Next slide, please. Next slide. So I'm going to talk also about the telemedicine regulations. I'm going to start, and then I'm going to hand it over to Scott, this is only valid for during the public health emergency. There was the 1135 waiver for Medicare that was effective March 1, and for Medicaid effective March 6. So depending on which waiver you look at, you can retroactively bill according to this. And we don't know yet what will happen post the emergency. And there may be new regulations that will come out at that time. Next slide, please. So at the moment, the expansion during the public health emergency is applicable to the whole of the United States without any geographic restrictions. At the moment, patients that are new or established can be seen, and this is applicable to even physician assistants and nurse practitioners. They're allowed to use telehealth services as well. Physicians or providers are allowed to waive copayment or make sure that they do have the payment paid for, but it's better to do one consistently, one or the other consistently. Next slide, please. And it's very important also to report this as a, because it's a telehealth coding requirement, you need to point out what the exact point of service is. So the point of service is 02 for an office visit and 11 for a hospital-based office visit. And based on this, there's also modifiers that one needs to put in. It's required, if this needs to be billed as a telehealth visit, that the modifier 95 is used. And there has to be an interactive audio and video telecommunication system. That's why these, I started off with the platforms. And if a patient has to have a subsequent inpatient visit, there is not that limitation of once every 3 days, and you can use the 99231 to 99233 for these. Next slide, please. So at the moment, CMS is revising the policy to see the EMN level of selection is based on medical decision-making or time, and it's maintaining the current definition of MDM. So these are the typical times that you use typically to see the patient as an outpatient. And this only applies to office or outpatient visits. That is furnished by Medicare telehealth. And it's only during the COVID-19 pandemic. So I'm gonna turn it over to Scott now. Thank you.
All right. Let me get that up. You should be looking now at the slides. Let me get back to where we were. Okay. So Mamta has talked a little bit about documentation of the telehealth services that use the 99231 to 233 codes, as well as the standard codes for day-to-day E&M codes. Telehealth CPT codes also have some HCPCS codes associated with them, but the most common telehealth codes we're going to use and that we're using for this right now are actually going to be your standard E&M codes, 99201 through 99215. typical outpatient or other office visits. You can also use the G0425 to 427 codes for telehealth consultations or emergency departments, or if you have initial inpatient consultations. And the outpatient discharge management codes, which are global, 99234 to 236, are also available as telehealth codes. At a level below the full-up telehealth visit, which requires two-way audio-video communication, there are a variety of other forms of telehealth that can be done. There are virtual check-in visits. Normally, historically, these were only available to be billed for established patients, but in the waivers for the public health emergency, they can now be billed for new patients, just as the existing G codes can be billed in that way. There are a variety of them. There's the G2012 code, brief technology-based service, really just essentially an email or other offline asynchronous communication, typically provided to an established patient, not originating from a related E&M service, so it has to be separate from another telehealth visit or an actual in-person visit, and is typically billed on time 5 to 10 minutes of discussion, and that's your 5 to 10 minutes of discussion. There's the G2010 code, which allows you to evaluate recorded video or images which are submitted by an established patient. In other words, if she uploads a picture, for example, of a rash, and you look at that and interpret it and follow up to her within 24 hours, again, not related to a separate visit, that would be the code you'd use for that. These can be conducted with a much broader range of communication methods, unlike the telehealth visits. So they offer a bit more flexibility. These can be done in all locations, the patient's home, any real area, not just rural areas, but in the middle of big cities. This can be done with patient-initiated communications through patient portals if your EMR supports such a thing. Most do. And that way they can do this without leaving their shelter-in-place locations. And again, these services are billed either with CPT 99421 to 423 or the G codes we just talked about. The patient must verbally consent to receive these services, and you do need to document that. As with all these services, Medicare coinsurance and deductible would apply, but you are able to waive those copays associated with those visits. And then here's a rundown of the differences between them. 421 is 5 to 10 minutes. 422 is 11 to 20 minutes. 423 is 21 minutes. Again, these are the cumulative time over 7 days used in the evaluation and management services associated with those codes. So you get to, if you email a patient, if you have an email with an encounter with a patient, and then they send, and you spend 10 minutes or 5 minutes making that email, and then they send you an image and you take a minute to look at that image the following day, and then 2 more minutes to write them a follow-up email, you can total those together over the 7-day period. The G codes allow clinicians who are not independently able to bill for E&M visits. For example, physical therapists are the obvious ones. For people who have PTs in their office or associated with their practices, this allows a PT to conduct virtual check-ins, virtual visits with their patients as well. Telephone call services historically were never really reimbursed. CMS is finalizing now for the duration of the emergency separate payment for the CPT codes for telephone management, 98966 to 968, and 99441 to 443. You can see the distribution of RVUs here below. This is appears to be what these are going to be reimbursed at least at least during the public health emergency. What happens beyond that, we'll all find out. So some examples. Consider a patient who's scheduled for an office visit related to urge incontinence. By telephone, she calls in to discuss her current symptoms. She's doing well. She's got no untoward side effects. She asks if you can call in a prescription. You answer her questions regarding that prescription and that follow-up and suggest that you get together and evaluate the situation after the emergency is cleared. She thinks that's a good idea. So you send in a 6-month prescription of a beta-3 agonist. You document the phone call and the note of acceptance and understanding the telephone encounter and the possible responsibility for typical copays, etc. You document a typical HPI and appropriate review of systems, make an assessment and plan, document your medical decision-making. You document the phone call time lasting about 10 minutes. You give a diagnosis of N39.41. And depending on the exact timing of that, you can either use 99441 or 442, and whatever questions and whatever documentations are required there, can affect that. And you'll get somewhere between 0.25 and 0.5 RVUs for that visit. Similarly, you can imagine a patient who's scheduled to come in for constipation and mixed incontinence, but you call her because of the outbreak and offer her a telephone evaluation for her assessment and her improvement or lack thereof. You treated her about 4 weeks ago for this with pattern voiding, some behavioral modifications, and some treatment for her constipation. And at that point, her residual volume was documented as 125 cc's. She reports by phone now that the constipation is getting better. Her urgency is getting better, as is her frequency. She says she's still having some stress incontinence symptoms, but notes that she's not voiding as frequently and not having to get up at night. You talk to her about weight loss and about physical therapy. This entire process takes about 15 to 20 minutes. The diagnoses listed here, various CPT codes you might choose. Your place of service, of course, is your office, because that's presumably where you were when the phone call was made, or where you would have been if you had visited with her in person. And there are the RVU distributions expected there. Another example, patient is already self-quarantining, and she uses the patient portal component of the EMR to access and request information regarding her recurrent UTIs. It's a question that you don't find hard to answer and can easily give her an answer online. So you write her a response message back and send it. This is a virtual check-in, and you document it based on the amount of time that you spent creating it and putting it together. The distribution of our views is there. And it's asynchronous, right? You didn't actually talk to this patient. It was done as a form of electronic communication, analogous to an email or a text. Note, texting is not appropriate because it's not secure. And then finally, the one that we most think about when we think about telehealth, certainly what a lot of us are now doing, what I'm finding that my patients are really enjoying. Imagine a scenario where your institution is allowing Skype, for example, communication during viral emergency, and a new patient has been referred to you requesting rescheduling. Instead, you offer her an AV communication. She was referred for symptoms of prolapse, retention, pain, and some vaginal bleeding. She's had a prior evaluation by urology who suggested that she come see you. So she's amenable to this. Her daughter arranges for the appointment and helps her mom with the technology bit. And you do a virtual office visit using the type of technology we're now using to have this webinar. She's struggling with stage 4 prolapse as seen by the photograph that's provided to you on her iPad and shown to you through your Skype camera. I caution you that the descriptions for the codes for this specifically state that pelvic exam stuff should not be attempted by remote video. But obviously, if the patient has done it, you can't stop her from showing you such a thing. It appears that she's got some erosion of the vaginal mucosa. That seems to be the source of the bleeding. Of course, you can't rule out bleeding from the endometrium. So you talk about causes of bleeding, causes of prolapse, the way the pelvic floor anatomy works, and the potential for retention of urine. You talk about correction of these various issues, including evaluating the bleeding, talking about a pessary and some topical estrogen, maybe surgery. You get her started on some topical therapy and arrange for an appointment for a physical exam and a pessary fitting and an endometrial biopsy as appropriate. You document the diagnoses as listed, and depending on your time based and the degree of medical decision making, and you would use the time basis the same way you would use a normal E&M time code, so the time that it takes. For example, we do most of ours through Zoom. Zoom provides a timer on its standard application, and so at the end, I simply can look up at the top of the screen, see the time that's listed, write that down, and I document that time in my note as the face-to-face time with the patient. Again, your point of service is your office, because that's where you would have done it if you had been able to do it. Whether you're in the office or at home doesn't make any difference. And I generally also document where the patient is. You do need to document her consent to this as well. And there you can see the reimbursement. So I'm going to switch over now to Jill and let her talk about CMS policy changes and some of the relief issues that are available for people. And over to you, Jill.
Great, thank you, Scott. Scott's going to give me back the screen here. Just wait here a minute. I will. There we go. Great. Well, thank you all for spending a little time with me this evening. I want to talk about the policy changes that CMS has been making to enable many of these coding and reimbursement changes that we just spoke of. So, but I need to go forward, not backward. So one of the things that CMS has done, in addition to providing these waivers for telehealth services, is they've also waived some Medicare requirements regarding physician supervision to enable physicians and their staff to continue to practice together. So many times different procedures require direct supervision by the physician or the other practitioner, either to a nurse practitioner or a PA or a nurse, or to a fellow or a resident. So now direct physician supervision is no longer required for non-surgical extended duration therapeutic services provided in your hospital outpatient departments or your critical access hospitals. So,
hi, Jill, can you share your screen? We can't see your slides.
oh. Wait a minute here. I thought I had. Oh, I must have shared somebody. No. Can you see it now?
Yes, we can. You're good to go.
Okay, great. Thank you. So sorry. I must have reshared Scott's screen. Okay, great. Can everybody see the slides? Good. We'll go back then.
We're good.
Okay, so let's talk again about physician supervision. So as I was saying, it's no longer required for non-surgical therapeutic services in a hospital outpatient department or in critical access hospitals. So if your hospital is still allowing you to do therapeutic services in your hospital clinics for non-COVID patients or for COVID patients, you would no longer have to provide direct supervision to your staff, your clinical staff. Also, direct supervision can be provided by virtual technology. So that is a big change. And of course, this is all only during the public health emergency. So we have to remember that this will all go back to normal, possibly someday. So yes, now let's talk about medical licensure waivers. And CMS has waived medical licensure requirements for this public health emergency, particularly requiring, and this is very important for telemedicine, particularly requiring that a physician or non-physician practitioner, so if you have nurse practitioners, PAs, we're waiving the requirement that they must be licensed in the state in which you are actually practicing. So again, if you're seeing a patient over a state line, providing with them with telehealth, CMS is waiving the requirement that you must be licensed in that state. You, however, must be enrolled in Medicare. You must possess a valid license in the state in which you do practice. You have to be furnishing services via telehealth or in person, and you cannot be excluded in some way from practice in the state. So you can contact your provider enrollment hotline for questions if you need to ask for other licensure-based waivers, and the waiver does not have the effect of waiving any state or local licensure requirements, right? So you still need to understand your own state's local licensing requirements. But this, there's been a lot of talk about the ability to offer telemedicine services across state lines with a single state license, and these waivers will allow that to happen during this public health emergency. So another area that has, again, been waived is this concept called the Stark Law, or physician self-referral. We have long had rules in the Medicare program about physicians not being able to refer services to facilities for which they have an ownership relationship to. You see this a lot in imaging, pathology and lab, radiation oncology, physician-owned specialty hospitals, et cetera. So CMS, to create more capacity during the COVID-19 crisis, has waiving some of these stock law requirements, are also waiving the fact that hospitals could provide physicians with some compensation around meals, laundry service, personal clothing, childcare services while they're taking care of patients with COVID-19. Also allows a physician practice to offer capacity of equipment or other sort of capacity to provide services below market value as a way to help provide surge capacity for COVID-19. Another very big piece of this waiver is physician-owned specialty hospitals can temporarily increase their number of licensed beds, their operating rooms. This is actually currently prohibited under regular Stark law. So that's a big change for those hospitals if they choose to do that during this public health emergency. Similarly, with imaging services, mobile vans that offer imaging services could come in to parking lots that a group practice owns the parking lot and offer services where normally they could not do that. So another piece of the CARE Act that is very important to physicians, and we actually hope to get this number on Monday or Tuesday of next week, is that effective for all services offered to Medicare fee-for-service beneficiaries between May 1st and December 31st, 2020, the conversion factor will be increased to restore the 2% sequestration reduction that's now been on the conversion factor for over 10 years. And so we'll be interested to see what this 2% increase to the conversion factor to provider payments, how it actually impacts the number. Right now, each RVU is worth $36.09. So it'll be above that number for sure. And we should have the exact number early next week. CMS is about to publish another interim final rule with comment period to not only contain this, but the hospitals are getting relief from sequestration. There's also some other telehealth things that CMS is going to clarify around the telephone codes and around the, I think there's been a lot of confusion around the point of service. And so that'll be in that rule as well. They'll give some examples and things, not unlike we've done on tonight's webinar. So that is going to be coming. The other thing that it's good that this is coming, is hot off the press. Some of you may have looked at your MSN as you were getting on this webinar. The administration released their guidelines for reopening today, and one of their stage 1 reopenings, assuming your community had met the criteria around PPE and supplies and infection control and reduction in COVID cases, et cetera, is that there would be asking hospitals to open up elective procedures in their outpatient clinics or outpatient hospital elective surgical procedures. And then in phase 2, also open up their inpatient surgical elective procedures. So it's possible now that this Medicare sequestration reduction waiving starting May 1st in certain areas of the country, that'll probably impact revenues from Medicare fee-for-service sooner rather than later if they choose to open their elective surgeries back up. I actually just saw a grid that Oklahoma will be putting theirs back up in late April, and some other states are already looking at putting out guidance for early May. So those are some actual policies that CMS has waived. And also in the CARE Act, there was financial programs. One of them that's extremely popular that we're going to talk about has already run out of money, but rest assured, you did not get your application in yet. Do not fear, because there will be more money coming post haste within the next week to 10 days to 2 weeks probably. So this program that I'm about to talk about, the Paycheck Protection Program, has by far been the most popular small business loan program that probably the federal government has ever run. As of this morning, we are out of the $350 billion, but as I said, have no fear. Congress is looking to find an agreement to put in another $250 to $300 billion into the program, and that will probably happen possibly as early as next week. So it's still a very good time to go to your bank, work with them. These are for loans are for small businesses, businesses that, when I say small, less than 500 employees, so not that small. The majority of the loan would be for payroll costs, mortgage insurance, benefits, utilities, et cetera, but 75% of your loan amount is going to be to cover payroll. These are also very low interest loans. They're 1% loans. However, and this is very important, if you maintain your payroll and if you furlough people, you can bring them back. So the loan backdates to February 15th. And then if 2 months from now, you have 75% of your payroll still there, the loan is forgiven. So it basically becomes a grant. So this is really, unless you are, planning to lay people off, this is a really good way to hold on to your clinical staff, hold on to your administrative staff, and be able to have the federal government pay for their salaries. Now, there are some salary caps. It can only pay up to $100,000 of a person's salary. So for those in your practices that are making more than that, you'll have to supplement that with a different loan program. We'll talk about some others here in a minute, or from other state, local funding, or funding from the practice. But it is the ability to cover quite a bit of payroll costs. Applications started April 3rd. It's been extremely successful in regards to applications, and most banks now are up to able to get the applications in, work with you on calculating your eligible amount, getting the different attestation forms together. So really encourage folks who have not applied for any programs yet to sit down with your bankers if you need funding to keep your practices going. Even faculty practice plans, if you're under 500 employees, the faculty practice plan should be talking to the bank if you need dollars to keep everybody together as we go through this COVID-19 crisis. So another loan program that still has money, but it is small amounts of money, hasn't given out as much money, is the Economic Injury Disaster Loan Program, EIDL. Now these funds were supposed to go out very quickly, even though the loans could be up to $2 million. Most of them have been more about this $10,000 immediate emergency, $10,000 to $15,000 to $25,000. So these loans, I have actually not heard of anybody getting their checks yet. But you can apply for an EIDL and what we call the triple P, the paycheck protection that I just talked about. They're not mutually exclusive. They can't be used for the same costs, but they can be used together. And again, this is why talking to your accountant, your banker, sitting down and mapping out which costs you're going to apply for which program are really important. But this program, the checks have not gone in the mail yet, but the applications are available. The banks have them. They're happy to work with you. And we hope that people will apply if they need to. So the Treasury Department is running these programs, even though it's the Small Business Administration. They have all of the applications online. They have all of the rules for the programs. They have great fact sheets. So we have the link here. This will also be on the AUGS COVID-19 webpage, which we hope you all will visit and visit frequently, because literally there is a new piece of information coming out almost every day that we're getting out to you as fast as we can on that webpage, and also through the Friday newsletter. And if we need to have another webinar because more information has come out, of course, we'll do that. But definitely this is important. Now, there's also a pot of money called the Provider Relief Fund, and this is all grant money. This is not loan money. You would not pay this money back. Last Friday, $30 billion of the fund is worth $100 billion, was distributed to providers via their registered tax identification number with Medicare. So not your NPI number, not to individual physicians, but to the entity for which you are assigned that bills your claims and gathers your normal Medicare revenue. So if you're in private practice, your practice has a TIN number, tax identification number. If you're in a big practice group, and are employed, either your hospital or your practice group, whoever your employer is, has the TIN number. So so $30 billion was distributed electronically on Friday. It went through electronically to your Medicare account, to the account that gets your Medicare revenue from United Healthcare. United Healthcare Optum was the portal for CMS to do it. And it's about 30 days worth of your Medicare revenue. However, you do need to go, the online portal is open now. I actually was on it earlier before this webinar. You do have 30 days. You have to attest that either your practice was disrupted from COVID-19 or you're seeing COVID-19 patients. But you do have to attest that you were somehow negatively impacted in your capacity to provide care to patients during this COVID-19 crisis. So that has to be done within 30 days. We do anticipate some additional money going out tomorrow out of the fund, mostly though to hospitals and hotspots and providers that predominantly serve Medicaid, like children's hospitals and pediatricians, maybe OB too. So we'll see what happens tomorrow. As I said, something happens almost every day. Then there's another loan program that CMS is running called the Accelerated and Advanced Payment Program. This program is eligible to all Medicare providers. You do have to build a claim within 180 days. You can't be in bankruptcy, and you can't be under a program integrity review or an audit with the Medicare program or have any delinquent Medicare overpayments, which you probably don't. But the top three are important, and you can qualify for this program. Now, this program comes to you through your Medicare administrative contractor. They've all put the forms on their website, and they are where you go. They're processing these loans in about 4 to 5 days, and CMS as of Monday had given out $53 billion. Now, there are some problems with these loans in regards to the repayment and the interest rate if you don't get it all paid back. But we at AUGS with our surgical colleagues and the AMA are working to fix that. So if you can't qualify for the triple P and you need money, this may be a program for you to investigate. As I said, the repayment process starts at 120 days, has to be repaid within 210. There is a bad interest rate on the balloon payment, but these are things we're all trying to fix. And so if folks need a loan program, this is a place to go. Okay, so I zipped a little bit there through the CMS Accelerated Program, but that was in part because we're going to get that program fixed. So hopefully you'll all do the triple P and get ready for that. So now let's take some questions. I'm going to stop sharing because I think that will bring up the question bucket. And right now we have 2 questions. And actually before I do that, I am going to, okay, so Colleen, do you have the screen now?
Yes, it's just showing everyone's videos.
Okay.
Yep.
So now, okay, so clarify please how resident physicians in an academic practice could use telemedicine and what supervision and documentation would be needed from the attending physician. Thank you. Well, you would no longer have to document direct supervision, which means that you are physically there with them in the practice, but you would be documenting that you are supervising their work, even if it's not physically in the same location. So you would document that you had worked with them on the care plan for those patients they were seeing. You would document that you had worked with them after seeing the patient, so that you are working with them on their care plans for those patients, but you're not physically there with them. Because of course in COVID-19, you would be social distancing and may not actually physically be in the practice with them. I don't know, Scott, Mitch, if you guys have been working Monta with residents and have put together any supervision templates.
Adding on the resident to your clinic panel, they can use your login information and just say that they're calling on your behalf, and you don't have to then add them on and then have to pay the extra if you were to choose to do it that way.
I don't have residents where I work, but I think Monta's probably right. And I think, Jill, you've got it. You just need to document appropriate supervision and that you reviewed with them the care plan and thought it was reasonable. That's probably all you need.
Yeah, great.
In fact, so it isn't.
So then somebody asked, does the CARE Act apply to academic medical centers? Do I need to look that up online within 30 days? So the CARE Act does apply to academic medical centers. They did get their share of the first $30 billion that went out because it was a calculated formula that CMS did. It was basically based on your 2019 Medicare revenue, what percentage were you or your TIN of all Medicare fee-for-service revenue for 2019. So whoever is the representative entity to CMS for that tax identification number is who needs to go into the attestation portal and attest. Because you do, having played with it tonight, I made up a fake tax identification number because the second question is, what is your tax identification number? So whoever is the keeper of that needs to be the one filling out the attestation for your practice or your academic faculty practice plan, and then your hospital staff will do it for their Part A money that they got, or Part B outpatient. So yes. So on the triple P loan, why are we backdating to February 15th? Well, in case, unfortunately, you had to lay off people or furlough people before you heard about the triple P program or before Congress passed it, they want you to be able to go backward and then not have to not lose the opportunity for it to turn into a grant versus a loan. So yes, you do have to submit proof eventually to turn it into a grant that you paid the payroll, you paid your rent, you paid your utilities from that date on. But the Small Business Administration and Treasury have not yet put out the forms that people will use to attest that they met that criteria of not laying off their staff, i.e. continuing to pay their salaries. And, but yes, you're going to have to keep records to submit proof that you continue to pay those costs. So we have another question. Anyone heard of some physicians being told about a pay cut? How does this figure into the relief fund?
I've heard all sorts of things.
Yeah, we have seen, unfortunately, articles in both the mainstream media as well as the healthcare media of some physicians looking at furloughs. There was also an article early on that some of the big faculty practice groups were no longer going to make 401k retirement contributions in 2020 for their physicians. I'm sure I'm sure there's been discussion about pay cuts or some sort of holdback. However, the relief fund doesn't take that into account. So if you are an employed physician, your hospital is getting money from the federal government, and they do not have to, unfortunately, if it's from the relief fund, they do not have to maintain payroll to get that grant money. They just get it. Now, if they're going into one of the big loan programs, there's another big one at SBA Treasury, that would be large, i.e. up to 10,000 employees. You could see some hospital systems doing. There are some requirements on that program around maintaining payroll, maintaining staff. That not unlike what the airlines are going through. It's a different pot of money, but similar requirements. So if your hospital was applying for that loan program or your system, then they would have to maintain payroll. Now, you know, how much of that payroll and et cetera, I haven't looked at that program to know if there's different rules about whether they can keep people but cut their pay. Yeah.
So go ahead.
Not that anyone has a crystal ball, but telemedicine is here to stay. What do you see as pros and cons of telemedicine for us in the post-COVID era?
I would say that the genie is out of the bottle. CMMS is going to have trouble putting it back in the bottle. So I agree, it probably is here to stay. What the details of that will look like, it probably won't look, I bet it doesn't look like what it looked like before, but it probably won't look like what it looks like now either. Jill, what do you think?
Yeah, one thing I think is that CMS will want to consider, because they're going to be concerned about costs, right? That's one of their big concerns overall, is should they be paying for an office visit, a 99201 to 99215, at the same amount of money for telemedicine office visit as one that's done in a practice setting, because the cost profile is not the same. You don't have all the nurses there. You don't have the overhead. You don't have the rent. And right now, the practice expense part of CPT code payment is based on your practice cost for providing that service. And that's why the office pays more than the hospital clinic, because the hospital provides those practice expenses. So I do think there will be a discussion about long-term what the payment levels should be on telemedicine codes and whether they should have their own codes versus using the regular E&M office visit code. So stay tuned. But in this interim final rule with comment that we're going to see early next week, it's possible CMS will already say that they're going to be making some of these things permanent through their red tape initiative, where they think they have authority to get rid of certain barriers and things. So I think we'll know some of this a little sooner rather than later, a little bit on the permanency of a few of these telemedicine things.
Hey, Jill, this is Mitch. Can I say something real quick?
Sure, you bet.
there's been some thought. In fact, there was a paper presented at AUGS about a year ago about using telehealth in terms of doing post-op visits and things like that. And if we start going down that road before this is all approved through CMS, it really could affect our values on these services, because currently they're valued for in-face visits. So I think we need to be sure to tell everyone that, or let everyone know, hey, we're all looking at this, but we have to kind of tread lightly as we do this.
And that sort of brings up the one last point that I wanted to make with all of this. And I think it's time to start thinking about wrapping this up. But we need to, Mitch's point is right on. We need to be very careful. This is something that's going to get looked at very carefully when this is over. We don't want to abuse it. It's certainly here to help the patients and to help us help the patients, but it is not something that should be thought of as a separate revenue generator or, a kind of a cash cow. This is not the cash machine you go to. This is the, oh my gosh, how do I take care of my patients in the middle of all of this stuff? And I think Mitch is spot on. We need to be careful to make sure that we're still providing good value, good quality of care, and that we're making sure that we dot all of the I's and cross all the T's, and that we're only using this in ways that benefit our patients, not necessarily ourselves.
Right.
All
And
right.
it's, yeah.
I think we're now at 3 minutes after 6. I think our hour is up. So I'm going to thank all of our participants for joining us this afternoon and this evening. The body of this will be available on YouTube if you want to look at it again. Or alternatively, if you have any further questions that haven't been addressed, we've tried to get to almost all of them. But if you have questions that haven't been addressed, then there is a coding Q&A question process that's available through the AUGS website, and we would invite you to share your questions with the coding committee through that portal. Colleen, I think we're done.
Great. Thank you for attending.
Yes,
everyone.
thank you so much, everyone. Thank you to all the panelists. Thank you.